Hope you guys are doing well. So today we're going to talk about surgical interventions and post-op management. These are our objectives. You can read through them. I'm not going to. All right, why would somebody have surgery? So oftentimes it's because they have so much pain at rest that they just can't tolerate it. That they have significantly limited motion, that the joint is very unstable, there's a deformity or a bad alignment that's causing them issues. If the structure has damaged or degenerated significantly, if they chronically have joint swelling in that area, if maybe they had a previous surgery that didn't heal appropriately, or if they're at a point where they just have such a loss in function that they can't continue in that way. Some of the considerations for pre-op management. So physical therapists will do pre-op PT, and when they're doing their initial eval, they would do evaluate the pain, the range of motion, the skin, muscle performance, posture, gait analysis, functional status. Now, why would we do preoperative physical therapy? We want the muscles to be in the best shape they can be so that they heal appropriately. So build the muscle up so that it can then heal better and unite, reconnect itself together better. The other thing is they also have some preoperative visits with the medical doctor that checks into a lot of this stuff as well to see kind of what to expect and if the person's healthy enough for surgery and things like that. All right, so this is the one with the medical doctor. So typically you come in, do a little tour of the hospital, fill out your paperwork, and then they give the patient some general education materials. One thing you don't want to do is wait until the day of surgery and then educate a patient, because most of the time they've had some type of a medication that might alter their ability to understand and follow your instructions. And so if you wait and give the person instructions the day of, it's likely that they're not going to remember those instructions. But the other reasons they do this, just to decrease anxiety, educate the patients on precautions, what things they need to do before and after surgery, or what to expect during surgery, if they need somebody to drive them, if they need to get an assistive device or any special equipment beforehand, all those types of things. They also will often talk to them about their weight-bearing precautions or any other precautions that they may go home with. So some of the things we educate on during the pre-op visit, and this is primarily nurses and doctors, not typically physical therapists, this is at the hospital setting, is the plan of care, precautions, how to now do bed mobility and transfers, exercises like deep breathing exercises, ankle pumps, things that they want to do right after surgery, gait training, how to properly care for their wound, and then this is just a general statement that if they have pre-op physical therapy, it typically improves their post-operative gains and their ability to heal properly. Post-op management, these are just some things we're going to go over about post-op, what the exam and evaluation looks like, what factors influence rehab after surgery, some phases of rehab, some potential complications, and then some common surgical procedures. So during our initial eval, we check their range of motion, strength, we look at their walking again. If they had a surgery on their leg, then we certainly want them to use their assistive device and their brace, anything they came with. We watch them take off and put back on the brace, make sure that they're independent with that and don't need any pointers there. A lot of people need help with that. A lot of people don't know. I've heard people come in with the brace upside down or backwards or anything. So it's definitely important. We assess the wound and make sure it's healing okay. Take measurements of their edema, give them questionnaires about their function, and then educate them and help them with transfers and functional mobility so they're able to move around safely. Factors that influence post-op rehab. So extent of damage, extent of pathology, what type of surgery they did, any factor related to the patient, you know, if they're a go-getter, if they're kind of nonchalant, stages of healing for the tissue, the patient's response to immobility, their body's response as well, their response to therapy, the health and the integrity of the surrounding structures, and then the philosophy of the surgeon. There's some that are very aggressive, some that are very passive, and so that can affect the patient's outcomes as well. There are 3 stages of post-op management, just like the stages we learned last week in the healing, stages of healing, how we have the minimum, moderate, and maximum protection phases. So we start out in the maximum protection phase. You're trying to protect the surgery and not do anything that could possibly harm it. Typically, it lasts about a week, 6 days or so, but in some people who either have slower healing or the tissues were not as viable and not as healthy, it could last up to 6 weeks in the maximum protection phase. So especially if it's somebody that they're doing a revision of a surgery that went wrong to begin with, they didn't heal appropriately the first time, they're going to be very careful what they do. Then the patient will move into the moderate protection phase. It starts when the maximum protection phase is over. How you know that? One, the surgeon may send some details like progress treatment or progress weight bearing or now cleared to begin active range of motion or things like that. So you may see words like that in the chart that tell you they're now in the moderate protection phase. And if it just says progress as tolerated, what you can start to look at is the inflammation. Once the inflammation starts to go down and the patient isn't in pain at rest and the pain and the tender areas are starting to minimize, then you know they're starting to move into that moderate protection phase. Now, this typically lasts about 4 to 6 weeks, could be significantly longer if the individual isn't as healthy. And it involves, you're starting to gradually increase the level of stress or tension placed on those tissues. So, doing more range of motion and more stretching and more active movements, things like that. And you're just slowly progressing the tension that you're placing on those structures so that they're able to slowly build up their strength and be able to tolerate more and more resistance. And then in the minimum protection phase, we also call this the return to function phase. The doctor has to release them to this phase. So sometimes you'll see the doctors now release to full weight bearing or release to return to sport or return to activity or return to prior level of function, or you may just see to progress as able, as necessary, or different statements like that. Our focus here is restoring function. The surgeon must release them. Typically, you want the patient to have full or close to full pain-free range of motion in order to start this return to function phase. And then a stable joint capsule. If there's a bunch of instability there, we still can't increase the demands on that joint or you will cause another injury. Typically, this starts about 6 to 8 weeks after a surgery and can last 3 to 6 months. Again, everybody's tissues are different, so it may be different for different people. Something we're going to do in lab. All right, some of the complications that you may see post-operatively, and we'll go over a few of these. Pulmonary complications, deep vein thrombosis, pulmonary embolism, subluxations or dislocations, restricted motion, scar tissue formation, failure, displacement, loosening of internal fixation. So we'll go over a few of these things more specifically. With a DVT, deep vein thrombosis, the signs and symptoms, there's typically pain and swelling, heat and redness in an area. Oftentimes it is the lower leg, but it could be other areas as well. In order to reduce the risk of somebody getting a DVT, which we absolutely want to do, you want to have them elevate the leg whenever they're laying in bed, not sit for long durations, move around pretty often if they're able to. Start walking as soon as possible after surgery. Most surgeries, they try and get the patient up walking in the first day or 2 after the surgery. And that's key in helping circulate the blood so that it's not just sitting in an area and pooling, which causes blood clots. Ankle pumps are a very good way to increase circulation, to decrease the risk of DVT. And then compression stockings can also increase venous return and minimize the pooling, which would cause a DVT. And in the picture, these are sequential pneumatic compression units or devices, where it's like a sleeve type thing that goes over the patient's leg or arm, and it blows up to compress certain areas, and then it relaxes. So it kind of acts like a muscle pump in pushing the blood back to the heart, and can help increase circulation and decrease the risk of a DVT. Signs and symptoms of a pulmonary embolism. So if suddenly someone has a sudden onset of shortness of breath, which we call dyspnea, if they have rapid and shallow breathing, which we call tachypnea, chest pains that are worse with deep breathing and coughing, leg swelling, anxiety, fever, excessive sweating, which is called diaphoresis, cough, or blood in the sputum, which is hemoptysis. All of those are signs of a pulmonary embolism. And a pulmonary embolism can be life-threatening. If you suspect that any of your patients have that after a surgery, you need to immediately talk to the doctor about your suspicions so they can get checked out. How do we manage a patient who has been diagnosed with either a DVT or a pulmonary embolism? So typically they will get some anticoagulant therapy. So those are blood thinners to try and thin that clot out and dissolve the clot. They're placed on bed rest because if the clot moves, it can go to another area, which can be even more damaging. Remember, if a clot goes to the heart, it's a heart attack. If it goes to the brain, it's a stroke. And if it goes to the lungs, pulmonary embolism. Is there one more place we're supposed to say? None of these are good, though. We don't want this. So you want to dissolve the clot and not just move it to another area. Once a patient's got this diagnosis, we cannot do active or active assistive range of motion of that body part. So if it's a leg, then you could do some things with the arm, but not the leg that's involved. We do not put heat on that area. That will dilate the blood vessels and will allow the blood clot to travel, which we do not want. We do not use those pressure pumps that I was just explaining about, the sequential pneumatic compression pumps, after they've been diagnosed with a DVT, because again, it can push the blood clot somewhere else. So if they've been diagnosed with something like that and then they're released from the hospital and allowed to go back home, they can certainly not do any contact sports, running, skiing, anything that could cause them to have a high traumatic impact until they're at least off the blood thinners, and the doctor would need to be able to release them to some type of activity like that because they're at a risk for bleeding either internally or externally because their blood will have difficulty clotting because they're on blood thinners. If they are riding a motorcycle or doing something like that, they certainly need to wear a helmet, but they just need to be very careful during that time. Some of our surgical approaches that we're going to go over: an open procedure, an arthroscopic, and then a arthroscopically assisted or semi-open. So with the open procedure, they make a large cut. They open the whole area up, see everything they need to work on, put their tools in there, and then close the area back up. Sometimes this can be used for a joint replacement, arthrodesis, internal fixation, soft tissue repair, and reconstruction. These take longer to heal. It's a very big incision, a lot of tissue damage, so it's longer to heal, but it's easier for the surgeon to see what they're working with. With the arthroscopic procedure, they just make these tiny little incisions and just big enough to place their tools in, and so typically they have a camera in one area and a tool in the other, and usually there's at least 3 incisions, sometimes even more, so that they're looking at a TV screen and watching where they are so they know exactly where to go and how to proceed with the surgery. So it's very small incisions. They place an endoscope and many surgical tools in those incisions. It can be done in an outpatient surgery procedure, patient center, and it's a lot shorter healing times, less painful, less likely to get infection, things like that. But it is a little difficult. There's certain surgeries that cannot be done that way. With an arthroscopically assisted, or a mini-open, I said semi-open, mini-open procedure, they have the arthroscopic tools, but there's also an area that they have to open and in order to either place something in or pull something out that's larger than those little small openings. So sometimes if they're using a skin graft, they'll have to open an area big enough to be able to pass that skin graft in and do what they need to with that. If they're taking out like an appendix or something like that, there's probably an area that they have to open large enough so they can get that appendix out. With a tissue graft, an autograft means it's from your own body. Allograft, it's from a donor, like a cadaver. And then synthetic graft, it's an artificially made material. It's man-made. It's not from someone's body. Those are the type of grafts you can use. This is a way that they make like kind of a mesh out of a skin graft in order to spread out the surface area that it covers. And then your body can heal up small openings in the skin, but once it's a large opening, it cannot close that gap on its own, depending on how deep the wound is and what layers of the skin have been damaged. And so this can act as a way of giving it extra coverage and allowing it to close up all those gaps. Muscle repair, typically we want to repair muscle after muscle's been torn within 2 to 3 days of the injury. So 48 to 72 hours, 2 to 3 days after a muscle is torn, it needs to be repaired in order to go back to its previous length and elasticity. If it's sitting in there for a while before it's repaired, you're not going to be able to stretch it to its initial length, and so you'll have to anchor it down somewhere new. Typically the muscle is sutured, it's sewed together, and it's immobilized in a shortened position. Now these are key because we're going to go through muscle, ligament, and tendon, and you're going to differentiate between whether it's in a shortened position, a neutral position, or a lengthened position, and how many hours after the injury you must repair it in order for it to be repaired appropriately. So those are key points. It needs to be repaired within 2 or 3 days, and it needs to be in a shortened position. Some of the considerations with somebody you're treating after they've had a muscle that's been sewn up is muscle setting exercises. You have to be careful because even just isometric contractions of that muscle could be damaging. You have to just be careful as to whether or not they're allowed any active movement of that muscle at that point or not. But typically muscle sets are allowed. Active range of motion exercises in a controlled range, so not going throughout the full range, can help promote your joint mobility and prevent contractures. But there's typically a period of immobilization, so you'd have to wait till that period is over. Typically weight bearing is restricted if it's in the lower extremities until tissues can stand the amount of stress without causing more damage. If you're doing any exercises, you want to do low load, high repetition exercises, and you want to progress very slowly and try to avoid pain when possible. With vigorous stretching or full activity, that is contraindicated until the healing is over. So till you can say the muscle has been completely healed, you do not want to vigorously stretch a muscle that recently was repaired or to do any high impact activities. With a tendon repair, that may happen if there's been a severe trauma or some type of chronic impingement going on, but the tear needs to be repaired immediately. Within hours would be ideal. Within days is absolutely necessary in order to limit the retraction of the tendon. So after a few days, the tendon starts to also shorten, and then you cannot connect it to the right place. And if you connect it in a different place, it's going to completely change the action of the muscle that it's attached to. So you just really have to be careful about that. They require longer immobilization periods because there's not as much blood supply, so it takes longer for a tendon to heal. Some of the considerations that we want to talk about for tendon repair, you can typically start muscle setting or isometric contractions of a muscle immediately after the surgery. You can start some passive range of motion and then some activation of the opposing muscle, the antagonist. You can start some controlled motion against gravity, but that may be a few weeks into their therapy before you can even start that. Typically, weight bearing is restricted if it's in the leg. And then there are contraindications for at least 6 to 8 weeks after a surgery on heavy lifting, because that would be too much strain, too much tension on the tendon. And then, yes, it's hard to get full range of motion back after a tendon's been torn because they may have to either move where the tendon is attached to the bone. It may not be able to fully attach in its original place. And also, when it's damaged, it starts to shrink some. So full range of motion may be difficult in patients like this. Some of the common places that they need tendon repair are biceps tendon and Achilles tendon. With a ligament repair, remember ligaments connect bones to themselves, bone to bone. The surgeon first has to approximate and suture the ends of the torn ligament. So they have to get the two areas close enough together and then sew them up. Typically, you immobilize them in a lengthened position in order to put some pressure or some tension on the ligament so that think about there's two bones and between them is a ligament that's connecting them, okay? And it's holding them stable. So ligaments provide stability. However, and if it's torn, then we got bones moving around. That's not good. However, if you put them too close, then as you move, we have now bone-on-bone interaction, which is going to be painful. It's going to be damaging to the surfaces. It's eventually going to cause arthritis. So you want them in a lengthened position so that there's enough space between the bones that as there's movement, they're not bumping into each other. So with ligaments, you want them in a lengthened position. With muscles in a shortened position. And with tendons, I believe it's just in a neutral, kind of a neutral position. During immobilization, the duration of immobilization varies by site, by the severity of the injury, and by the type of surgery performed. So it could be very different in one patient versus another. So typically early on, you really protect the motion, you really limit the motion, and then you very slowly, progressively start strengthening, weight bearing. You want to slowly start loading a healing ligament, meaning you want to slowly add more and more tension for it to get used to so that it can see what to do. And then you're going to progress differently based on the type of surgery that they did and whether they used a autograft or an allograft, what type of sutures. If they had to anchor it into the bone, sometimes they have to kind of burrow into the bone and anchor the graft into the bone, which takes longer to heal. And then by the stability of the site. Remember, we definitely want stability here because that's really why ligaments are there in the first place. So if an exercise is going to challenge the stability in that joint, then we want to avoid that. So the two different types, allograft, as you see, and here's kind of a hole in the bone that they've made in order to pull it through and anchor it down. Or an autograft, sometimes they'll use like the patellar tendon, cut a little portion out of the middle of it, and then use that as a ligament that they transfer somewhere else. Capsule reconstruction. So if somebody has recurrent trauma or dislocation or symptomatic subluxation, so it comes partially out and it's painful. then it might be indicated for them to have their capsule repaired. So remember I talked about the capsule being like the old pair of underwear. Once it's stretched out, it never comes back to its original size. So the only way they can get it back to the original size is to go in and either cut part of it out and sew it to itself, or fold it over onto itself and sew it. They have to just basically shrink it and sew it to itself. So the different types of surgeries they can do, they're all done to decrease laxity, so to increase stability and decrease laxity of the capsule. So a capsulorrhaphy, okay, is also known as a capsular shift. That's what you'll hear more commonly. And you cut into the capsule and then tighten it by overlapping it and sewing it to itself. Capsulolabral reconstruction, you reattach the labrum to the rim of the joint, and then you add some stabilization of the capsule by sewing it, lapping it over and sewing it to itself. The electrothermally assisted capsulorrhaphy is where they take a laser or a radio frequency and they deliver it to the capsule itself, and it uses heat to shrink the capsule. So those are kind of the three types of surgeries they may do in order to fix a loose capsule or an instability problem. But the main focus here is stabilization. Always stabilization. Capsule has stability. If there was laxity there and that's why they're having surgery, then you need to promote stability. So because of that, they may delay treatment altogether in order to avoid loosening the area up while it's healing. So they may wait until the area is fully healed before they actually allow therapy, because they want to make sure that the stability is there. A tendon transfer. So they could transfer the tendon at the muscle tendon unit, which would increase stability of a joint by altering the line of pull, force generation, muscle excursion, but it would not change the action of the muscle tendon unit, and that's immobilized in a shortened position. So if they transfer a tendon near the muscular tendon unit, it needs to be in a shortened position, just like if a muscle was affected. It will alter the line of pull, but it will not change the action of the muscle. With a tendon transfer from one bone to another, like if there is hypertonicity and they need to lengthen the area or prevent deformity or whatever, this does change the muscle action of the one it's attached to. So with a tendon transfer from one bony surface to another, it changes the action. So basically you've changed the origin or the insertion site, and so that changes the line of pull and changes the action of the muscle. So whereas before it pulled straight up, now it might pull to the side or something a little bit different. Some treatment considerations: if there have been a tendon transfer, you can do isometrics or muscle setting. You want to protect motion. Resistance exercises are progressed very slowly. Make sure the tissue heals. And then biofeedback and E-stim are often used to increase their motor control, their muscle contractions, and help them kind of reintegrate with the new change in that muscle. Here is an example of a tendon transfer. So the extensor pollicis longus was damaged and it was too short to reconnect. So they moved that over and reconnected it to, what is that, extensor indices? I don't know what the P stands for. But now the thing is, you are going to have, rather than two muscles that are helping move the pointer, now you'll just have one. But that's a tendon transfer. It still changes the line of pull a little bit for the thumb. All right, with a soft tissue release, there's different ways you can do soft tissue releases. Otomy means to cut into. So myotomy is cutting into the muscle. Tenotomy is cutting into the tendon. Fasciotomy is cutting into the fascia. With a fasciotomy, the reason they may have to do something like that is if there's so much swelling underneath that it's actually damaging the tissues, and the tissues are going to die if you don't get the swelling out, then they'll do a fasciotomy and they'll cut through the fascia and let some of that swelling out. A Z lengthening is another procedure that you could do to release a tight heel cord or Achilles tendon, where you cut a Z pattern in the tendon and then you pull it apart and sew back together kind of the two ends of the tendon, so it gives you some extra length. Immediately after any of these surgeries, you want the CPM. Remember, that's the continuous passive motion machine. And then you want to continue with active range of motion so that they do not lose range of motion. If there is some type of a release, that means before it was too tight and now you've released it so that it's got greater length, and if you don't use that length, you lose that length, and it will go right back to the tight muscle or area that it started out, and you'll have the same issues. You want to strengthen the antagonist, because remember, strengthening shortens a muscle, so you can strengthen the opposing muscle and it will give an inhibitory signal to that muscle and allow it to lengthen a little bit more. And then you want to do activities that use that extra length functionally, because people are more likely to use that and to do that more often to be more compliant. So make sure you're finding some functional activities that patients can do. Functional activities patients can do as they are healing. All right, with joint procedures, there is arthroscopic debridement and lavage, so they go in and clean it out. If there's maybe a bunch of bone spurs or, areas that are not smooth anymore and causing pain. Synovectomy, they remove the synovial membrane. Articular cartilage procedures, just depending on what's needed. Arthroplasties, and then arthrodesis. So some of the contraindications that would keep somebody from being cleared to have a joint replacement. So TJO is just total joint replacement or arthroplasty. Is if they have an active infection in that joint, if they have chronic osteomyelitis, so inflamed bones that are more brittle and easier to damage, if there's a systemic infection, if they have significant bone loss or tumors that prohibit an area to adequately implant the bone, because whenever they do a joint replacement, they have to cut into, they basically saw off a portion of your bone, remove it, and then they just hammer in a metal bone to the end of the bone that they just sawed off. So like here, they would saw off at the neck of the femur, and then they would just bang that metal piece all the way down into the bone. So if the bone is brittle at all or has any damage or difficulty healing or something blocking that area, then either it will not heal around the area, or just the banging into it could cause the bone to shatter. So we don't want to do that. If the muscles around the area are significantly paralyzed, then they won't be able to use the joint, so then it would be contraindicated. Neuropathic joint, you can also call that Charcot joint. So these are weight-bearing joints, and they start to deteriorate and cause deformity. So we've talked about that with diabetes before, where the tissues have just become really soft because they're sitting in excess fluid that is not nutritional. It's now toxins just sitting there that can't be pushed out. And so then they're highly likely to have fractures and things like that, even with just normal walking around, because the bones have become so soft. And low patient motivation. If we know the patient's really not going to do anything with it, no point in trying. All right, ORIF, open reduction internal fixation, ORIF. We use pins and screws. So this is like if somebody breaks an arm, they go in, cut into the area, they get the bones realigned, and then they put a rod and some screws to keep it in place, and then they close it back up. So that's open reduction internal fixation. You open the area up, you reduce the gap in the bone or wherever, the malalignment, then you fix it internally. You put screws, pins, plates, whatever you need in order to fix it. And that is ORIF, open reduction internal fixation. There's also such a thing as an external fixator. If you've ever seen somebody with the halo on that's kind of keeping their head in place, it's like screwed into their bone, and it's keeping their neck still so that the neck can heal properly. I'm sorry, without causing a spinal cord injury. And that's an example of an external fixator. Something externally that's keeping everything in place. Some of the treatment considerations for ORIF. You want to always protect the fracture site. You want to get the patient up and down as early as you can, just to avoid the other damage that can happen with immobility, or like at risk of DVT or skin breakdown or any of those things, contractures, any of those things that could be possible. And then the progression just depends on the severity of the fracture, the patient's age and health status, and then how the surgeon actually fixed the area. Since it is actually fully stable from the inside out, they do not need an external stability device, so they don't need a cast. They probably don't need a brace unless maybe some other structures were damaged, like maybe they had a car accident and they not only had a fracture, but they also had torn ligaments or something like that, then they might. But for the fracture itself, they do not need also extra external fixation after they have this type of procedure, because it is stable enough from the inside. Osteotomy, remember otomy means cut into, so this is cutting into the bone. So they surgically cut into and realign the bone. It could be maybe if a bone had excessive growth, or if it had it could be a lot of different reasons. Some of the treatment considerations: if they need to be immobilized, then make sure you at least mobilize the joints above and below that area. Once they're allowed to progress to active, once they are allowed, then you need to progress them to active motion and to strengthening. And then typically with someone like this, with any type of bone injury, typically weight bearing is limited for the first 4 to 6 weeks while the bone is really healing. Could be longer for an older person as well. All right. Some require casts, some do not. It just depends on the surgical procedure. All right, and we will do that in class. So that is our surgical interventions and post-op management. Just let me know if you have questions.